doctors. A warm welcome to all in this very exciting and scientific session. The topic of the today's session is very interesting. That is double trouble in diabetic hypertension improves outcome through 24-hour blood pressure control in combination therapy. And to guide us in this topic, we have very experienced in hypertension and diabetic management, Dr. Soumya Das Patnaik. And as you know, all of
Hello. कौन है भाई? So, good evening, everybody who has joined. Hope you all are doing well in this pandemic situation. So, before starting my presentation, I would like to advise all my juniors and colleagues, please, all of us, we should stay safe. We should save our skin first, then we should serve. Okay, thank you.
Louder voice is coming very low.
Okay. So today we have a discussion on topic double trouble. Uh, the double trouble is diabetes and hypertension, and improving outcome through 24 hours BP control with combination therapy. So we should move on. How if a patient comes to us with both hypertension and diabetes, so how we should improve his blood pressure control? That we will discuss in further slides. So here is a picture, blood pressure and diabetes, and these are two vicious twins. And the study says hypertensives are 2.5 times more likely to develop diabetes within 5 years of developing hypertension. So there will be some complications like microvascular complications, and stage renal disease, which is attributable to both hypertension or diabetes. Obviously, retinopathy, and stage renal disease means nephropathy. Then, so far heart is concerned, some macrovascular complications. So a patient will most likely 3 times likely to develop coronary heart disease, 2 times likely to develop LVH, left ventricular hypertrophy, or concentric LVH, or left ventricular strain, and 3 times likely to develop CHF, congestive heart failure. So 40 to 80% of diabetics have hypertension, and diabetics are 2 times likely to develop hypertension. So And in so far our arteries are concerned, diabetes mellitus increases peripheral vascular resistance and risk by 2 to 4 times, and increased risk in proportion to the severity of blood pressure. More severe is the blood pressure, more will be the risk in diabetic people. And so far brain is concerned, cerebral vascular accidents will be more. So next slide will go. So hypertension and diabetes, how both increases risk to each other. How hypertension and diabetes increases the risk. 4.4% of deaths of diabetes is contributed by hypertension. So if a person is diabetic, so 4.4% of that persons, if the mortality is contributed by hypertension, and 10% death of hypertensive is contributed by diabetes. If a person is hypertensive and he is suffering from diabetes, then 10% death is contributed by diabetes to a hypertensive patient. So hypertension increases risk for diabetic complications, like proportion of diabetic complications attributable to hypertension. So if a person is diabetic, how hypertension increases the risk? Hypertension increases the risk in a diabetic patient. The risk of stroke increases by 75%, coronary artery disease by 35%, end-stage renal disease by 50%, and eye disease like retinopathy increases by 35%, and leg amputations out of complications of peripheral vascular disease by 35%. Next slide. So, what is the present scenario now of deadly DO, both hypertension and diabetes? So, currently, India is the world's capital of diabetes. So far, diabetes is concerned, India is capital. Either I think China. After China, India is leading in diabetes. So every fifth person in India is diabetic, and 171 million in 2000 to 366 million by 2030. It is expected to rise from 2000 to in 30 years to 366 million. Okay. So, and all of you know what is the reason. Soon on the way to becoming the hypertension capital. We are, India is on the verge of becoming the verge of getting that obvious distinction of becoming the hypertension capital. One out of every 3% is hypertensive here. Again, because of stress, because of our lifestyle. So, twofold increase in hypertensive population expected from 1975 to 2000. Already 2015 is gone, so 594 million from 1975 to 1.13 billion 2015. It's the data of it's the actually this is the statistics. So one out of every two diabetics has hypertension. This is all statistics in India. The present scenario is like this: one out of every two diabetics has hypertension. So our challenge is how to manage the hypertension in a diabetic patient, how to manage diabetes in a hypertension patient. So we will focus in this presentation, we will more focus on how to control the blood pressure of a diabetic person, which is very much challenging. You must be facing in your day-to-day practice. Next slide. Uh, the data says each 10 mm of mercury reduction in blood pressure reduces micro and macrovascular complications in diabetes. So, if we reduce the blood pressure by 10 mm of mercury, then microvascular and macrovascular complications of diabetes is also reduced. So, tight blood pressure control and risk of macrovascular and microvascular complications in type 2 diabetes. This is the US UK prospective diabetes study group. So, how you can see in the picture how in tight control blood pressure, how the risk is reduction in percentage of risk is how it is reduced. Diabetes related endpoints deaths related to diabetes, stroke, MS, all are reduced by tight control of blood pressure. So next, intensive BP lowering in diabetic patient, HOT trial, hypertensive optimal treatment trial, that is a randomized trial. So this is the picture again. If you intensive means aggressively, if you lower the blood pressure, then how risk is reduced in a diabetic person. Effects of intensive blood pressure lowering and low dose aspirin in patients with hypertension. So more or less, what I do actually, if a patient is coming with high blood pressure, then I either start low dose clopidogrel 75 mg or low dose aspirin 75 mg with starting. So that his or her blood pressure will be more controlled. So that is called intensive blood pressure lowering. So that we can reduce the risk. Next slide. Mm, Blood pressure target in diabetic hypertensive. So this is the guidelines, American Heart Association 2017 guidelines, again European Society of Cardiologists 2018 guidelines, International Society of Heart 2020 guidelines. So all are saying our target blood pressure always should be less than 130 by 80, unless a patient is suffering from one or two diseases. CKD, I think chronic kidney disease, and one or two disease, where 140 by 80 can be the target. But most of the guidelines recommend always our target should be less than 130 by 80. So, next slide. Mm, Blood pressure control is more important than blood glucose control. You should also remember diabetes. So you can see diabetes related endpoints and death related to diabetes. So by strictly controlling blood pressure, how we can reduce the risks. If we control BP strictly, then 25% reduction in diabetes related endpoints. Whereas diabetes related risk will be 12%. So always, if you control blood pressure strictly, then risk will be more reduced. But only half of the hypertensive patients with diabetes reach BP target with monotherapy. This is the challenge we are facing in our day-to-day practice, in our outdoor or indoor. Mm, when a patient comes with first presenting to us, so he's suffering from both diabetes and hypertension. We are writing ARB. So sometimes it is difficult, or most of the time it is difficult to control his blood pressure or her blood pressure with a single drug. So achievement of BP goal in diabetes often requires the use of combination therapy. So, but this is all the data from studies, different studies. The study is saying always combination therapy is preferred over monotherapy. More than one half of the patients require two or more drugs to reach their goal blood pressure. So more than one of the participants, this is the picture of a trial, and more than 30, one half, not more than 50% of the patients participants, they require two or more drugs. So if you start ARB or ACE inhibitors, then calcium channel blockers, then diuretics, then other drugs. So it is seen more than one half of the participants they required two or more drugs to reach their target blood pressure. So, so what is the rationale? Rationale for combination therapy is ethical. So combination therapy can reduce blood pressure to a greater extent and achieve the blood pressure goal more promptly. When high risk condition exists, an event may occur within a relatively short time interval. So an event may occur. when high risk condition exists, high risk, the person, the patient who is very high risk, and any event, cardiovascular, cerebrovascular event may occur within a relatively short time interval, requiring protective interventions to be implemented without an excessive delay. So, the patient is coming with 190 by 100 blood pressure, which the end organ you feel that it might be hypertensive emergency, it might be which end organ damage. So we can't wait more. We have to reduce the blood pressure immediately without an excessive delay, so that further any complicated event can be avoided. So in several trials, the protective effect of blood pressure reduction became manifest shortly after initiation of the BP lowering agent. So the protective effect immediately manifests. So, so initial combination treatment may be associated with a lower degree of treatment discontinuation. So again, diabetic patients. This is again data, trial data. These are different randomized trials where in the left it is written. These all are trials, randomized trials. And diabetic patients require second and third drugs more frequently than non-diabetic patients. If a person, what study saying is, if a person is only hypertensive, there is no history of diabetes. So most of the cases, the blood pressure can be managed by a single drug. But if a patient is both diabetic and hypertension, then he or she requires more often. He or she requires either second drug or third drug more frequently to reach its target blood pressure. So again, this is combination therapy versus monotherapy in reducing blood pressure. This is an again meta-analysis on 11,000 participants from 42 trials. These are all trials what I am presenting to you. This has been collected from the various sources, and this is the and what is the summary? The summary is the combination therapy, and the combination therapy is always superior than monotherapy. So again, data saying the combination therapy is always better than the doubling the doses of sample. If a patient is coming to us and he is taking amlodipine 5 mg, so and his blood pressure, his target blood pressure is not achieved. So some physicians they write, okay, you take twice daily. So that what study is saying that always combination therapy. We can add another group of drug, then doubling the sample. Some drug. So initiating with two drug therapy in diabetic patient. Aggressive treatment with initial use of this combination leads to systolic blood pressure goals being achieved in more diabetic patients than with monotherapy, regardless of baseline systolic blood pressure. So combination drug um, always achieve the systemic achieve reducing the systolic blood pressures, which is more in diabetic patients. In diabetic patients, it is always tough to reduce the blood pressure with a single drug. Um, so we use more than one drug to achieve the target blood pressure. So again, the same thing. The study is saying always combination therapy is more superior than single drug therapy. So this is again a landmark trials that confirms the role of combination as initial therapy that is well accomplished, avoiding cardiovascular events through combination therapy in patients living with systolic hypertension. So um, again, study saying we can avoid any cardiovascular event by reducing the patient's systolic hypertension in a diabetic patient by uh, more than one drug therapy. This is new generation hypertension trial assessed single tablet combination therapy for initial treatment of high risk hypertension. And the initial therapy was with RAS inhibitors, calcium channel blockers versus RAS inhibitor hydrochlorothiazide was evaluated. So this is again a trial. It was done. Patient was given medicines and antihypertensives. Then for the results, so always um, more than one drug is preferred over a single drug in a diabetic hypertensive patient. This is again another study, that is the renal study. Reduction of endpoints in non-insulin dependent diabetes mellitus with the angiotensin II antagonist losartan. Again, these are the studies. Um, uh, this is all studies. This is again, if you add any angiotensin to SE inhibitors, which ARB, losartan or SE inhibitors, then 78% with baseline CCB treatment. So either SE with CCB or ARB with CCB. There is 32% reduction in fast hospitalization with heart failure, 35% reduction in proteinuria. So guidelines also acknowledge need for combination therapy. Combination treatment is one of the options for initiating drug treatment in diabetic hypertension. In diabetic patients, CCBs, calcium channel blockers, and low-dose thiazide diuretics should be used in addition to ARBs for BP control. So sometimes it is seen CCBs causes peripheral edema, so thiazide diuretics is added. So what is the preferred combination therapy? So European Society of Heart or European Society of Cardiology, they say what is their approach for combining antihypertensive drug classes. So this is again a study. Um, Thiazide diuretics, SCV inhibitor, SC inhibitors, beta blockers, and ARBs, calcium channel blockers. So ARB or diuretics and ARB or CCB are more rational combinations available in a single pill. So so you can see the pictures. So this is the summary. You should prefer angiotensin receptor blockers like telmisartan or agilsartan, with or valsartan, losartan, whatever you are preferring. Most of the cases in the FD we are preferring telmisartan and agilsartan. Nowadays we are using agilsartan with diuretics or telmisartan with amlodipine or cilnidipine, whatever. So CCB plus ARB advantage. How what is the advantage? Both have synergistic mechanism of action. Both synergize each other. Both increases the performance of each other. Vascular protective effects due to the improvement in endothelial distinctions. Neutral metabolic profile. Nephroprotective effect due to its capacity to dilate the renal arterioles. Reduced incidence of edema secondary to the use of calcium channel blockers. So what it is telling, we'll see in the next slide. The peripheral edema created because of calcium channel blocker that can be attenuated by ARB. So greater capacity to reduce morbidity or mortality rates in high-risk hypertensive patients than the RAS inhibitor diuretic combination. So again, it is telling that um, always ARB and CCB is preferred over ARB's diuretics combination. How synergy and counter regulation, CCB and ARB. This is what CCP is doing here in reducing blood pressure, dilation, peripheral edema, effective in low renin patients, reduces cardiac ischemia. Calcium channel blocker is given, it reduces cardiac ischemia. And what ARB is doing is it is blocking the RAS, and but it is giving benefit to renal and congestive heart failure. As it is angiotensin receptor blocker, so it is blocking the RAS, renin angiotensin system. Then what ARB is doing here? how they are counter-regulating each other. You have seen in the picture. ARB is again doing CCB is doing arteriodilation, and here ARB is doing venodilation. So as ARB is doing venodilation, so obviously it is attenuating the peripheral edema, which is which CCB is doing. CCB is doing peripheral edema. So it is attenuating, it is reducing the peripheral edema. Effective in high renin patients, no effect on cardiac system. ARB is no role. CCB is reducing cardiac system. So CCB, ARB is blocking the renin-angiotensin system, and CCB is blocking, activating the renin-angiotensin system. So it has no renal or CHF benefits, congestive heart failure, but ARB has. So that's why cardiologists most of the time prefer Telmisartan, because CHF benefits is there. It helps in cardiac remodeling. So this is the synergistic BP reduction complementary clinical benefits. So what we are discussing here, we will discuss here is preferred calcium channel blocker and angiotensin receptor blocker combination therapy. So Amlodipine and Telmisartan is the preferred combination therapy. So far, at a normal outdoor, at seeing the patients, and most of the time, this is the CCP and this is Amlodipine Telmisartan is the preferred drug of choice combination therapy. Amlodipine. So this is the these are various CCBs. Amlodipine, and this is azilindipine, benidipine, cinidipine, manidipine, nifedipine, nitrendipine, lacidipine. So again, we know it everybody. It shows the highest half-life among all the CCBs. So amlodipine has the longest half-life, so it reduces the blood pressure in a sustained way. And amlodipine is the most studied CCB. Among the different CCB, what we saw, amlodipine is the most studied calcium channel blocker. It has been most the study is saying amlodipine is helping in reducing all the risks of a diabetic hypertensive patient. So again, this is telmisartan is the longest half-life and highest selective PPAR gamma activation. PPAR is the peroxygen proliferator activator receptor. So there are different subtypes: alpha, beta, delta, and gamma. So PPAR, what PPAR gamma subtype does is it is sensitizes the insulin. So, in a diabetic hypertensive patient, telmisartan, what telmisartan does cardiac remodeling, ARB, and it also does selective PPAR gamma activation. So, it is sensitizes the insulin, thereby reducing the blood sugar. So, this is the picture, longer half-life. Telmisartan again has the longest half-life among all the ARBs. And then telmisartan, olmesartan, losartan, valsartan, sandostatin. We are using other two sartan, agilsartan and another is thamsartan. So the study is not much available. While I know, while I was doing I was in care hospital, Soumya, sir. I have worked there for 2 years in cardiology ICU. So when Agilsartan launched in India, and Dr. MP Tripathi took a seminar, and he had told at that time, we have little evidence of how Agilsartan is an excellent Agilsartan, telling about Agilsartan. Agilsartan is an excellent blood pressure reducing agent, but how it is helps in cardiac remodeling or reducing the risks, that is still to be studied. So as it has not been studied, so it has not been added, I think. So among all the statins, telmisartan has the longest half-life, and it has the benefit of PPAR gamma. So it also benefits the diabetic persons. Telmisartan most studied amongst ARBs. Again, we had discussed amlodipine is the most studied amongst CCBs, and this is the most studied among ARBs. And these are all studies that I am presenting. Again, this is the study, the cardiovascular renal continua of disease and studies evaluating the efficacy of telmisartan. So how cardiovascular risk is decreased, how that renal risk is reduced, how telmisartan preventing endothelial dysfunctions, microalbuminuria, macroalbuminuria, macropoteinuria, nephrotic proteinuria, and end-stage renal disease. Again, atherosclerotic events, myocardial infections, remodeling, ventricular dilatation, congestive heart failure, and stage heart disease. This is all studied. And what we have found is telmisartan again helps in cardiac remodeling, again preventing end stage renal disease. So, amlodipine plus telmisartan is a combination therapy we will discuss here. Switching patients with uncontrolled blood pressure to a single pill combination of amlodipine plus telmisartan. Telmisartan and amlodipine single pill combination versus amlodipine monotherapy for superior blood pressure lowering and improved tolerability in patients with uncontrolled hypertension. So this is again a study. So always the same thing. Always telmisartan and amlodipine. We had discussed before. Always a combination therapy is more superior than a monotherapy. And again, this is a study. Telmisartan and amlodipine combination therapy is more superior than a blood pressure lowering agent in a diabetic patients. Then single monotherapy. Either with amlodipine or telmisartan. In stage 1 and stage 2 hypertension, um, 3 out of every 4 patients achieved blood pressure control. So we know all what is stage 1, what is pre-hypertension, what is stage 1 and stage 2 hypertension, then resistant hypertension. So 3 out of every 4 patients achieved blood pressure control in stage 1 and stage 2 hypertension with telmisartan and amlodipine. Early use of amlodipine plus telmisartan for rapid achievement of BP. So we should always try, if a patient is coming, okay, 150 by 90 is your blood pressure. Okay, it will fall down with the time. Don't worry, that should not be the attitude. But I feel it should be rapidly reduced for rapid achievement of blood pressure. We should early use amlodipine and telmisartan. Blood pressure target can be achieved more rapidly using a combination as initial therapy than with either monotherapy. So this is the blood pressure goal. This is all statistics again. Week 1, week 2, week 4. Then change in systolic blood pressure. That is the percentage. This all has been written here. So always combination therapy reduces the blood pressure more efficiently. Again, amlodipine plus telmisartan this offers 24-hour blood pressure reduction because both amlodipine has more than 24-hour half-life and telmisartan has more than 24-hour half-life. So that's why both of them offers 24-hour blood pressure reductions. That is the benefit we get from amlodipine and telmisartan combination. So 50% patients achieved more than 50 mmHg reduction in systolic blood pressure with telmisartan and amlodipine. Again, this is the study. Similar blood pressure reduction in diabetic and non-diabetic subjects. So 95.7% patients showed BP response with both amlodipine and telmisartan combination. In severe hypertension, single pill combination of telmisartan or amlodipine in patients with severe hypertension. Results from this is the study. 8-week randomized double-blind control study. 858 patients with severe hypertension that studied, and mm, reduction in blood pressure. So with the combination therapy, blood pressure is reduced. Blood pressure variability as compared with various monotherapies, The telmisartan or amlodipine combination was associated with smoother blood pressure reduction over 24 hours. So, uh, because of their half-lives, so we achieve smoother blood pressure reduction as compared to the monotherapy, which telmisartan and amlodipine. We get better result. So, as we know, again here it is daytime, nighttime blood pressure. So, as we know, blood pressure is always variable. Blood pressure is never constant. So, always ambulatory blood pressure measurement is the accurate method to measure blood pressure always. So, blood pressure measurement is we measure the blood pressure in the OPD. Okay, if people person comes, okay, your blood is this. But it is never the right result because in night time blood pressure is low, and at the morning time because of peripheral vascular resistance, our blood pressure increases. So blood pressure is never never same. So ambulatory blood pressure measurement is the right way. Again, there is white coat hypertension, office hypertension, home hypertension. So that's so night. That's why you have written daytime, nighttime. So what it is seen is the telmisartan amlodipine combination therapy is associated with a smoother BP reduction over 24 hours because of its half-life. Amlodipine and telmisartan for CV protection. Um, CV cardiovascular protection. So, amlodipine cardiovascular protective effect, efficacy in landmark studies. These are again trials and studies. Outcome is 20% reduction in primary endpoint was the composite of death from cardiovascular causes. Mm, non-fatal MI, non-fatal stroke, hospitalization for angina, resuscitation after sudden cardiac arrest, and coronary revascularization. So 20% chance is reduced. So actually, why it is necessary to reduce the blood pressure or to give accurate and proper antihypertensive. So what I feel all of you must have realized that I have felt while working in 2 years at care hospitals. The patient comes with MI. Okay, okay. Normal patient having chest pain, angio is done, and left ventricular ejection fraction is 60%, 50%. Okay, stent was given. Then patient is okay. After 3 days, he is discharged, and every 1 month, 2 months, he is following up with his cardiology. But sometimes what happens because of poor control of blood pressures, because of increase in risk factors, patient come with severe MI, and patients LVF is 20%, 25%. Then any intervention, any type of intervention, whether it is coronary CABG, coronary artery bypass grafting, or PCI, percutaneous coronary intervention, this is not possible. Because left ventricle will not function, heart is not functioning properly. So it is always more riskier to do an intervention at that time. So we should always mm, give the patients the proper and accurate medicines so that the complications can be reduced. This is all what studies say. Telmisartan is the again only ARB with a broad indication for cardiovascular risk reduction. Again, what I told earlier, telmisartan program of research to show telmisartan and organ protection. Telmisartan protecting our kidney, telmisartan protecting our arterioles, and telmisartan protecting the helping in cardiac remodeling. That is very important. So these are all studies. So always found that telmisartan is superior than other mm, medicines like acid inhibitors or losartan, other ARBs or thyroids. So this is the study again, and only ARB the telmisartan with a broad indication for cardiovascular risk. Telmisartan is equivalent to ramipril in patients with vascular disease or high-risk diabetes. So, Telmisartan, ramipril are both in patients at high risk for vascular events. So, this is again the study. So primary composite, the main secondary outcome there is telmisartan is better, ramipril is better. So telmisartan and ramipril are equally efficacious. Ramipril is a C inhibitors and telmisartan is a ARBs. So always ARBs or C inhibitors are um, always preferred, either ARBs and SE. This is the first preferred drugs in hypertension. So, first study is saying that Telmisartan both both in patients at high risk for vascular events. Mm, so relative risk is reduced in both Telmisartan and by using Telmisartan or Ramipril. So always Telmisartan can be preferred. Better effect on cardiovascular risk with good tolerability compared to acid. Effect of the angiotensin receptor blockers like telmisartan on cardiovascular events in high-risk patients intolerant to ACE inhibitors. Those who are intolerant to ACE inhibitors, because it is seen that ACE inhibitors they um, dilate the renal arterioles, they more cardiac they have more helpful in cardiac remodeling. So if they are intolerable to SE inhibitors, if cough occurs, sometimes what happens, we have given enalapril, ramipril to a patient started coughing. So stop the SE inhibitors and start ARB. So if they are actually intolerant, so next option is the ARB and that is telmisartan. Amlodipine and telmisartan for renal protection again. So this is again a study. Amlodipine plus telmisartan combination therapy. It offers uh, nanoprotections, renoprotection. Sorry. So this is UACR product, urine albumin creatinine ratio change from baseline. So amlodipine telmisartan reducing the UACR ratio. Amlodipine. This is the renal protection benefits. Renal outcomes with different fixed dose combination therapies in patients with hypertension at high risk for cardiovascular events. A prescribed pre-specified secondary analysis of a randomized control trial. So 11,506 patients with hypertension who are at high risk for cardiovascular events. So 48% reduced progression to suicide. So again, this is the renal protection benefits of amlodipine. So it is seen that amlodipine is also reduces the progression to suicide. Again, telmisartan prevents progression of microalbuminuria. That is innovation studies incipient over ARVs investigation in type 2 diabetic nephropathy. 163 microalbuminuric patients were studied, and it is seen that telmisartan prevents the progression of microalbuminuria. Um, Even these are the trials in telmisartan in renal protection trials. So telmisartan also protecting the has the renoprotective effect. Uh, mm, and we had already discussed here. This is the on-target trial where it is written telmisartan showed major renal outcomes are similar to ramipril. So it is efficacious to ramipril. If ramipril patient is intolerant to ramipril, we give telmisartan. So similar renoprotective as with valsartan also, telmisartan. So this is the study actually. So more or less telmisartan amlodipine they are providing the benefits. So safety and tolerability we should discuss about amlodipine plus telmisartan. Mm, So this is the we had already discussed CCB plus ARB reduction of side effect. Nanoscope because induce the CCB, that's why they cause peripheral edema. It is automated or reduced by administration of ARBs. ARBs by doing venodilation, CCB does arteriodilation and dilation, and CCB does arteriodilation, ARB does venodilation. But the venodilation it is reducing the edema caused by CCB. So always combination therapy is superior and it reduces the side effects. Addition of Telmisartan reduces the incidence of amlodipine related edema. This what we had already discussed. This is a slide which has been added. The antihypertensive efficacy of chlorthalidone and telmisartan in Indian hypertensive patients who are uncontrolled with hydrochlorothiazide and telmisartan combination, a prospective and open label study. This is actually this slide has been added. After ACE inhibitors and ARBs, we prefer calcium channel blockers. Then we prefer diuretics. So what the study saying is that always hydrochlorothiazide is always chlorthalidone combination with ARBs is more efficacious than ARBs with hydrochlorothiazide. So chlorthalidone is a high selling diuretics. So one risk it is an excellent blood pressure reducing agent chlorthalidone. And it decreases the diastolic dysfunction. This, and it also reduces the diastolic blood pressure. So, but one risk remains. I have also felt in my practice, realized as it is a high selling diuretic, it is causes hyponatremia. So we have to take care of that hyponatremia and always telmisartan powerful than is more efficacious than telmisartan hydrochlorothiazide. Thank you. So these are the discussions we had today evening. Hope you all enjoyed it. And so lastly, thank you everybody for present here. And thank you, Dr. Reddy. Thank you, Kanu Bhai. Thank you, Dr. Mani Bhai, Maji Bhai, for this evening. And
Thank you, sir.
lastly, I want to tell one thing. We gave effort. So actually, with the day-to-day practice, I prefer Amlodipine Telmisartan, that is Stamloti or Stamlot. So please prescribe Stamloti. Thank you.
Thank you, sir. Thank you for your very interactive and very practical session, sir, which is definitely boost our doctors in his day-to-day practice while choosing the combination therapy, and particularly in diabetic and hypertension patient, to set up combination therapy so it give them better results. And I'm saying, sir, to all doctor, you have if any query in the chat box, please type in the chat box. So Dr. Soumya Das answer it and queries. And there is very comments are coming from Dr. Kumar Naik, Dr. Samir Jana, Vikas Kumar, and to Dr.
Uh,
Sujani Pragyan.
Maji bhai,
Thank you, thank you everyone.
these
Yes,
all are my colleagues. All are my colleagues at Balime Hospital.
yeah,
One doctor is Dr.
okay,
Amir Jana is there. He is my friend from
yes,
Birla Medical College. He's now doing he's assistant professor in
okay,
medicine at some hospital. So I call him Bhai actually. So thank you Bhai for joining the
okay,
session.
okay.
It's a great privilege actually. Um, before presenting before you, Dr. Samir.
Okay, with this, I think there is no query, sir. So, with this, sir, on behalf of Dr. Reddy Division, I thank our speaker, Dr. Soumya Patnaik, and all the doctors as a participant for taking their time out in this evening and their busy schedules. Thank you, sir. Thank you all for joining this session. Also, sir, we are always as a company, we are always ready to do scientific sessions, and these sessions are definitely give benefits to you and your patients. Uh, so we are also patronized for that to do more. And so thank you, sir, once again, Somada sir, for so wonderfully describe about the topic and the benefits of the combination therapy in diabetes patients. Thank you all. Good night.